Hi, everyone. Welcome to today's presentation on the COVID-19 OT21-2103 Novel and Emerging Practice Studies, known as NEPS. Today's being hosted by the National Network of Public Health Institutes. This webinar today will feature 4 OT21-2103 recipients whose NEPS studies were evaluated by public health institutes and health research institutions as part of the national initiative to address COVID-19 health disparities among populations at high risk and underserved, including racial and ethnic minority populations and rural communities. On behalf of NNPHI, we are so excited to share this work. These health departments pursued innovative practices during a global emergency, and they were open to using evaluation to understand the effectiveness and implementation of their practices. We at NNPHI are lucky to partner with them in this work, and we see today as a celebration of all that's been learned in this process. My name is Dana Rosenberg. I'm a program manager for the Evidence to Action team at NNPHI, where I'm part of a team that supports this great work. I'm joined today by my wonderful NNPHI colleagues, Dr. Sabrina Selk, Dr. Robert Lachos, Alita Austin, Desiree Smith, Taylor Bonner, and Amanda Franklin. The NEPS evaluation work is supported by funds made available from the Centers for Disease Control and Prevention at the National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce through Cooperative Agreement OT18-1802, strengthening public health systems and services through national partnerships to improve and protect the nation's health. After today's webinar, our goal is for attendees to understand how the Phase 1 NEPS evaluation studies contribute to the evidence base for addressing COVID-19 health disparities under the OT21-2103 grants for strategy areas, which we will mention shortly. Here's the agenda for today's meeting. After today's welcoming remarks, Dr. Sabrina Selk will provide an overview of the goals of the NEPS evaluation in the OT21-2103 grant strategy areas. Then we will hear from each of our Phase 1 NEPS recipients and their evaluation partners. Following everyone's presentation, we will open it up for a Q&A. We will not record the Q&A portion of this webinar to encourage a free and flowing discussion section. Please enter your questions in the Q&A section of the Zoom, and we will answer questions during that portion. Before Sabrina provides the NEPS overview, I'd like to introduce my colleague, Tamara Lamia, who's the Associate Director for Evaluation in the Division of Jurisdictional Support of the National Center for Public Health Infrastructure and Workforce at the CDC. I'll hand it to you, Tamara.
Thank you, Dana. Welcome, everyone, on behalf of CDC's Division of Jurisdictional Support in the Public Health Infrastructure Center. We are really excited to be at the point today to have our 2103 recipients and CDC colleagues hear from our evaluation partners and the 2103 recipients participating in this first phase of the Novel and Emerging Practice Studies. When we were standing up this grant, we really saw the best practice work with NNPHI as an excellent opportunity to really start to understand select novel and emerging practices to address COVID-19 related disparities that are being implemented by our grant recipients, and that can help to contribute to this evidence base to support the growing area of work. So the novel and emerging practice studies are really one component of an evaluation of this grant. Other components of the grant are going to be coming shortly, so within the next 6-9 months or so, that are being led by colleagues in our Office of Data Reporting and Evaluation in the center, as well as in the Office of Health Equity here at CDC. So stay tuned on additional findings for 2103 recipients and folks as we moved into 2024. But I really want to thank you all for being here today, for also thank NNPHI, our evaluation partners, to really share this work, and for you all in your active listening, engagement, and questions today. So thank you so much for being here, and I'm going to turn it over now to Dr. Sabrina Selk, who is the Director of Health and Racial Equity at NNPHI. So Sabrina, take it away.
Thank you so much, Tamara. So as a refresher, our OT21-2103 grant recipients who applied for this evaluation opportunity identified their work as belonging to one of the 4 strategy areas of the grant, focused on Strategy 1, COVID-19 mitigation, Strategy 2, data collection and reporting, Strategy 3, infrastructure support, or Strategy 4, mobilizing partnerships. NNPHI, in partnership with CDC, collaborated with 8 OT21-2103 grant recipients to conduct evaluation studies of novel or emerging practice activities within their chosen grant strategy areas. This work occurred in 2 phases, with phase 1 starting in August of 2022. So the OT21-2103 recipients were identified as having either novel or emerging practices based on operational definitions of best promising emerging and novel practices created in the development of our online repository of COVID-19 best practices with CDC during the first year of this project. This table summarizes the abbreviated definitions and criterion used to distinguish levels of evidence. The NEPS evaluation focuses on novel and emerging practices that are being implemented at evaluation sites. As a refresher, emerging practices show potential to achieve desirable outcomes and produce early results that are consistent with the objectives of the activities and thus indicate effectiveness. Novel practices show potential to achieve desirable outcomes and are in the process of generating the evidence of effectiveness and may not be yet to be tested. Passengers in addition to the definitions, we can also envision.
Thank you for your cooperation.
Sorry. My slides are in a different order. Thank you. In addition to the definitions, we can also envision these practices as belonging in a continuum as seen in the slide. The continuum represents how the classifications are differentiated along the x-axis by the type of supporting evidence, for example, rigorous peer review or formative program evaluation, and along the y-axis by the frequency of the implementation in the context of a COVID-19 or in a similar pandemic environment. The purpose of the NEPS evaluation study is to understand and build evidence for novel and emerging practices implemented under the OT21-2103 grant strategies that can then be shared to improve both capacity and services that address health inequities related to COVID-19. The NEPS evaluation studies employs the REAIM framework, focusing on effectiveness and implementation of the REAIM dimensions. These dimensions were prioritized due to their ability to ascertain what works for novel and emerging practices. These evaluation studies will contribute to the overall CDC evaluation question: to what extent do grant recipients improve capacity and services to address COVID-19 health disparities and advance health equity among populations at higher risk that are underserved, including racial and ethnic minority groups and people living in rural communities? That concludes our review of the NEPS evaluation and strategy areas, and I will now hand it back to my colleague Dana, who will moderate the NEPS partner presentations.
Thanks so much, Sabrina. I'm going to hand it over to my colleagues at the University of Michigan School of Social Work and the Washington State Department of Health for their presentation on their NEPS evaluation study. I'll transition it to Dr. Daphne Watkins.
Thank you, Dana. So we want to begin by first expressing our gratitude to the NNPHI team and the CDC teams for allowing us to participate in this fantastic opportunity to evaluate novel and emerging practices across the United States. The first one that we had the pleasure of evaluating is at the Washington State Department of Health. And while there were several people involved in this really fantastic work, the folks who are here representing us today are myself. My name is Daphne Watkins. I'm a professor at the University of Michigan School of Social Work and also the evaluation lead for this project. And I'm joined here at the University of Michigan by my colleagues, Jamie Abelson and Hannah Burgess. And then from the Washington State Department of Health, we have Francis Limtiaco and Elizabeth Long, and you'll be hearing from them in just a few minutes as they present their novel and emerging practice. And in fact, I think we can go ahead and hand things over to Francis and Elizabeth to talk about the funding allocation methodology.
Thank you. Thank you, Dr. Watkins. Before I start, let me take the opportunity to thank NNPHI, CDC, and the University of Michigan for this wonderful opportunity to be a part of the evaluation studies for novel and emerging practices. So the Washington State Department of Health established the COVID-19 Community-Driven Outreach Program Initiative in early 2022. The goal of this initiative is to ensure that disproportionately impacted communities have equitable access to COVID-19 resources, and in doing so, also address related social conditions. At the onset, this was a $13 million initiative responding to priority communities and intersectionalities. The initiative's key principles are that communities are better positioned to respond to community needs, And they also have a unique understanding of trauma-informed approaches, access barriers, and risk perceptions that impact vaccine confidence and uptake. As part of this initiative, we developed and we piloted the equitable funding allocation methodology. However, the methodology was only one factor in funding allocation. Others were the number of successful bidders, the scope of proposals and funding requests, and community feedback, which itself became element 6 of the methodology. I'm now going to turn things over to my colleague, Elizabeth, who will describe the methodology.
Thank you, Frances. What we feel is novel about this methodology is that it strives to decenter whiteness in the data comparisons, and it also incorporates various data sources. And what really characterizes it is it's adaptable to community partner feedback and insights. I'd like to first acknowledge that there are some limitations to this methodology and that it's based only on some of the factors shaping differential COVID-19 outcomes and disparities. It doesn't account for other important social and institutional conditions that cause these disparities. We're looking forward to building on and improving this methodology. So on this slide in front of you, you'll see the 6 elements that make up the methodology. Element 1 provides a stable base funding. Element 2 provides additional funding for addressing any of the identified priority intersectionalities. Element 3 provides funding for the expected outreach, and this is calculated by the number of individuals being reached within the scope of the project. And element 4 is the most quantitative element, and it provides funding based on the COVID-19 health disparity. This is variable by the race and ethnicity category, and we chose to use COVID-19 hospitalization data as an indicator of health disparities to inform the funding proportions. To further decenter whiteness in this approach, we use the multiracial category as the reference group. Element 5 provides a base funding for equitable access to vaccination resources and information. And in element 6, this is where we listened and really incorporated the partner and community feedback and insight. I will turn this back to Frances.
Next slide, please. On this slide, you are seeing the 10 community-based organizations contracted representing all priority communities and the distribution of funds. In order to honor the principle that communities are better positioned to respond to needs and that community organization proposals were based on their organizational and community capacities and needs, we identified additional funding, bringing the total initiative amount to over 21 million. We then worked with each of them to ensure that 50% of their funding go to community-rooted organizations and that they engage their community to determine the use of additional funding, which was step 6 of the methodology. Next slide, please. This is a resulting community-driven outreach program network, or what we call the community component of our public health ecosystem. What started as 10 community contractors is now over 90. Our hope is that with this investment, it will pay dividends for years to come, because if we are able to sustain this, then the department will be well positioned to activate community partners for future public health emergencies. I will turn things back to Dr. Watkins.
Thank you, Frances. And so we had the pleasure at the University of Michigan School of Social Work's Curtis Center for Health Equity Research and Training. We had the enormous pleasure of evaluating this funding methodology. And so I think Sabrina mentioned earlier that all sites were asked to use the REAIM framework. And as you can see, there were several dimensions to the REAIM framework. We focused our evaluation on the implementation dimension for REAIM, and we had these 2 overarching evaluation questions that really guided our evaluation. The first was the equitable funding allocation methodology developed in a way that used a racial equity lens and prioritized intersectionalities embedded in communities that the funding was intended to serve? So essentially, was the methodology designed as intended? Our second evaluation question was the equitable funding allocation methodology applied consistently during the funding review and selection process? Or in other words, was it implemented as intended? And so just to speak a little bit about our methods, We used a participatory evaluation approach to determine the degree to which the funding methodology was both developed and applied in a way that improved capacity and services to address COVID-19 health disparities and advanced health equity among populations at risk. We used several different data sources to achieve our evaluation goals. For example, we used some existing documents that was shared with us by the Washington State Department of Health colleagues. We also reviewed some statewide data. We also collected a total of 20 interviews using 3 different interview guides, but of course, all 3 of those interview guides were tailored to the specific audiences that they were intended for, but they were all leading us towards answering our 2 overarching evaluation questions. As for data analysis, we used a modified version of the rigorous and accelerated data reduction technique. And we also reviewed some external data sources and extracted some additional information to address our evaluation questions. And you'll also see on this slide that in terms of our interview participants, we had 8 colleagues from the Washington State Department of Health participate. We had 6 community representatives, and we interviewed 6 contractors. So now let's talk a little bit about the evaluation findings. So in order to answer the first evaluation question, which was the funding methodology developed as intended? Our evaluation team determined that the equitable funding methodology was developed as intended. Responses from the qualitative interview participants suggested that the initial design and development of the funding methodology held racial equity and the intersectionalities embedded in communities in high regard. Interview participants also spoke about specific developmental processes and technicalities that, based on our analyses, also affirmed that the methodology was developed in a way that used a racial equity lens and prioritized intersectionalities embedded in communities that the funding was intended to serve. So after we had a chance to pour through the pages and pages of qualitative data, we were able to generate codes that then led to themes. And these 3 themes are what helped us address evaluation question number 1. So racial equity lens, prioritize the intersectionalities of communities, and development process/technicalities. Now, in order to answer the second evaluation question, which was the funding methodology applied as intended? Our evaluation team determined that applying the funding methodology allowed the teams in Washington State to pay close attention to some very important issues of equity across the state, but it was not a simple, straightforward formula. The complexity and interactive processes involved in using the funding methodology to make funding decisions made it difficult to apply it in a consistent and formulaic fashion. However, it was successful in part because of its flexibility. So while efforts made to use the funding methodology had a positive impact on many levels, given the focus on racial equity and the intersectionalities embedded in communities, it may have been a little ambitious to aim for consistent application of the funding methodology during its initial year of delivery. And so you'll see from this slide, we had 4 overarching themes that help support the answer to evaluation question number 2. And so as we begin to wrap up, I just want to present a NEPS highlight here, which focuses on lifting community voices through the equitable funding allocation methodology. So the issue starting out was that COVID-19 disproportionately impacted disadvantaged and marginalized communities in Washington. The impact was that Washington State Department of Health was able to address these health disparities impacting historically marginalized populations by including them and uplifting their voices in the process for both developing and implementing the methodology. And this is seen as a success story in many ways because it involved the community members in the decision-making process, and certainly it allowed them to have a seat at the table. And so just some suggestions here from the evaluation team as we begin to bring this to a close. With regard to plans for the future and sustainability, we advise the Washington State Department of Health and their respective affiliates to maintain the partnerships that have been built through this funding methodology development and application process, to continue positioning themselves as listeners, to continue to allow community members to have a seat at the table and uplift their voices, to continue to look beyond race as a determining factor for the work that's being done right there on the ground, to seek sustainable funding, because while receiving funding is really fantastic, consistent funding is even better. Also, permanent support systems are definitely very important for communities, and we heard that from the interviews that we conducted. And then finally, work a capacity building sustainability element into the methodology. And so for the closing remarks, I will hand things over to my colleague at Washington State Department of Health, Frances.
Next slide, please. Thank you. Thank you, Dr. Watkins. The process of developing the equitable funding allocation methodology was extremely complicated. We were trying to make change quickly in what was at the time unchanging contractual and procurement state systems, and during a global pandemic. The evaluation definitely allowed us to intentionally pause and learn from the process. Here are some of our key takeaways. How do we determine the weighting for community feedback and decision making? There really was no blueprint for this. In the case of the methodology, we gave it more weighting, given the community-driven program's key principles and our collective desire for meaningful change. We will continue to explore this with our team and ensure that our community partners have a seat at the table for this very important discussion. We learned that community participation as an element of the funding allocation process is critical to long-term recovery and resilience, given their deep knowledge and lived experience of the root causes of disparities that have no silos. We learned that communities do want to participate, be as deeply involved in discussions and contribute, but need support at times to do so. Permanent support systems, as recommended by the University of Michigan, are critical and exploring the potential of sustaining a digital hub model that we already have in place is on our list of things to do. We need flexibility when prioritizing community voices. This is critical if we are to meaningfully engage communities, to identify their funding priorities, to eliminate longstanding health inequities, and to ensure an equity and social justice lens in decision-making. Thank you.
Thank you so much, University of Michigan and Washington State Department of Health. I'm going to hand it over to my colleagues at the University of Wisconsin Population Health Institute, the Rhode Island Department of Health, and Brown University School of Public Health's People, Place, and Health Collective, or PPHC, for their presentation on their NEPS evaluation study. I'll transition over to Dr. Wajia Akhtar.
Thanks so much, Dana. Thank you so much, NNPHI and CDC, for giving us the opportunity to showcase our work for the COVID-19 OT21-2103 Novel and Emerging Practices evaluation study. We're excited to present today along with our colleagues at the Rhode Island Department of Health and Brown University School of Public Health's People, Place, and Health Collective. The University of Wisconsin's Population Health Institute is situated at the University of Wisconsin-Madison, and the work of PHIs focus on how we create equitable conditions for everyone to be healthy by advancing knowledge, practice, policy, and systems change. The Evaluation Research Group at the Population Health Institute is a team of professional evaluators and student trainees. We partner with community, tribal, county, state, and national agencies to develop, implement, and evaluate local and state programs in public health and human services. I'm joined today with my colleague, Salma Abedin, who's an action researcher and evaluator. I'll hand it over to Dr. Goodell, who will speak about Rhode Island Department of Health and his work at Brown University.
Thank you, Dr. Akhtar. I'm Dr. Will Goodell. I'm an assistant professor in the Department of Epidemiology at the Brown University School of Public Health, and I'm very excited to be here to represent an academic government partnership here in Rhode Island. I'm here presenting on behalf of my esteemed colleagues, Michelle Wilson, Chief of our Health Equity Institute, and Katie St. Amand, an epidemiologist and evaluator within the Health Equity Institute at the Rhode Island Department of Health, as well as Maxwell Krieger, who's a program director here in the People, Place, and Health Collective. Our practice leverages health equity zones, an initiative first launched by the Rhode Island Department of Health in 2015 under the leadership of a backbone agency, usually a community development corporation or a community action program that runs a federally qualified health center. Health equity zones, or HESs, bring together communities to build the infrastructure needed to achieve systemic changes at the local level. And through a collaborative community-led process, each HES conducts a needs assessment and implements a data-driven plan of action to address the unique social and economic circumstances that impact the health of residents in specific geographic areas across the state. These HES collaboratives are really on the front lines of many public health issues in Rhode Island, and were, a natural partner for COVID-19 response activities in the state's hardest hit communities. In working with our 15 HESs, we identified a need to improve capacity to use data for decision-making. So working together collaboratively as academics, where our expertise is in training and learning, and with our health department colleagues, where program implementation and service delivery is on their top of their list of priorities, we developed what we've called a Data Academy as an 8-hour course for leaders in each of the HESs. This course was really aimed at helping participants better understand how to use real-time actionable public health data to improve program implementation and service delivery to address COVID-19 related disparities. Over a series of 3 or 4 sessions, our HES members came together to focus on important building blocks for reading and interpreting public health data, particularly using maps, culminating in a session that trained them to use a web tool that we call Project Signal, that provided them with detailed data on COVID-related outcomes at the neighborhood level to guide their efforts to improve access to things like testing, treatment, and vaccines. And so we're in this practice, we're really focused on giving everyone a shared language for talking about and using data in decision-making. And so I'm excited to turn it back to our partners at the University of Wisconsin to discuss their evaluation efforts.
Thanks, Will. So I want to go over our overarching Data Academy evaluation question that we had. So we were looking at whether the Data Academy enabled participants to not only understand data, but also to engage community partners to use data to plan and implement evidence-informed prevention and mitigation activities to reduce the impact of COVID-19 related disparities. So the image you see on this slide is our theory of change. So really looking at the impact of the Data Academy on workforce and on communities, really to ensure that Rhode Island communities have the tools they need in order to create conditions for everyone to thrive. So from the RE-AIM framework, our evaluation focused in on effectiveness and really honed in on these 3 key questions. So to what extent did the Data Academy contribute to increased data capacity among HES network organizations? How effective was the Data Academy in strengthening the HES network and other community partners within their communities? And what key factors of the Data Academy contributed to mobilizing and building capacity among the HES network? And touching briefly on our methodology and data collection. So we had 2 key sources of data. So the learner surveys, which were surveys that were administered to participants following their participation in the Data Academy. These surveys were already collected by our partners at Brown and Rideau, and then shared back with us at the University of Wisconsin. And then the second source of data were focus groups, where we hosted and facilitated 2 focus groups. And this was an opportunity for participants of the Data Academy to provide feedback on their experience that they had with the Data Academy.
Thanks so much, Selma. And our results show that after completing the Data Academy, most participants reported their ability to use the tools they learned to guide their work and make decisions within their organizations. Focus group participants reported an increased ability to think beyond data points in isolation and about contextual factors that help explain the story behind data points. Participants reported that contextualizing data is important, and that Data Academy introduced learning how to communicate data as a part of a story to better reach audience. While not driven by the evaluation question asked, participants agreed that more resources such as templates and other resources on how to use the data would have been beneficial in how to apply their learning to their work. While thinking about the same evaluation question, as to what extent did the Data Academy contribute to increased data capacity among HES network organization? Most participants reported the ability to use tools they learned to guide their work to make decisions within their organization. Focus group participants reported increased ability to think beyond data points in isolation and think about those contextual factors that help explain the story. A lot of participants really named that they got enough information to be able to help interpret the data and increase their capacity to explain these data types points to people and how to apply that information. They were able to apply their learnings to understand broader social determinants of health and how that plays a role in health. And we'll talk about that in a bit in our case study as well. Dr. Goodell named this, and one thing that we heard at the focus group as well is that when there was when asked about increased collaboration among their own HES collaboratives in implementing evidence-informed mitigation and prevention strategies, the Data Academy participants named that it allowed the HESs to have shared language on how to talk about data, and this allowed for better partnerships and collaborations that ultimately led to more formations of outreach and partnerships and initiatives that they were able to do together. A library and healthcare system began working together to reduce vaccination rate gaps within their HES collaborative. A new collaborative between two HES is developed, and they were able to use evidence-informed approaches to create vaccination clinics to address vaccination gaps. Some participants report that they would have liked to practice more relationship building skills in small groups to be able to foster more of those initiatives together. When looking at the third evaluation question about what key factors of the Data Academy contributed to mobilizing and building capacity among the HES network, there was the Data Academy provided the necessary framework and some tools to assist with data collection, interpretation, and dissemination. And these tools were identified as being transferable for the use of other health priorities. And organizations reported improving their communication materials, such as their newsletters, and skills by using visuals and storytelling to share information. The mapping tool that Dr. Goodell had mentioned as well was useful to see how vaccination rates were evolving and where there were gaps. And this helped identify where to direct resources for our HES networks. Participants would have liked to spend more time learning about how to use the mapping tool and collectively sharing strategies to do more of that work to be able to collaborate and share knowledge together. And some participants would have liked to access a mapping tool so they could input their own data and see how outcomes change from there as well. As I mentioned, that there was ways that the HES network saw the Data Academy as a tool to be able to expand the work that they're doing, and one of them was a library staff member that used the Data Academy and understood how they could understand neighborhood level data and use resources that target more upstream factors. And they help this learner to connect the dots on what it takes to ensure that everyone thrives. So the public library used the Data Academy to understand how vaccine rates can be increased through solutions such as increased public transportation. The participant at the Data Academy noticed that vaccination locations were not necessarily convenient for a good portion of the city and began thinking about how transportation plays a role in our society. They took this learning and expanded it by working with the state library network to create a similar dashboard that the health department had to look at who in their state had a library card and who does not. The state library network built a similar process as COVID-19 dashboard to see what demographic groups, language groups, neighborhoods, transportation access, and other factors were likely to decrease the access to a library card. The participants learned that there is an intersection of multiple factors that are needed to understand what is associated with accessing libraries. And most importantly, this participant came out of the Data Academy learning how addressing something like transportation access can target so many downstream factors that can improve health. So our overall findings is that there was an overall satisfaction of the Data Academy, and participants perceived that the Data Academy training made them more confident, helped them understand their organization data capabilities, and that the material was digestible and appropriate. There are more opportunities that were needed to connect the dots with other organizations in order to continue the collaboration. Now I'll hand it off to our partners at Rhode Island to talk a little bit more about next steps.
Thank you, Dr. Akhtar. It's great to be back. I am so thrilled that we've had these evaluation findings because they've helped us tailor what our next sort of set of data academies should look like in terms of building in more opportunities for interaction between participants, as well as tailoring this for different audiences that may have different levels of background knowledge regarding the use of data in decision making. In a series of upcoming workshops, we're actually providing a version of this content for programmatic staff at the Rhode Island Department of Health so that these kind of common language and common approaches to data storytelling can be infused into all public health programming throughout the department, in which these HESs are embedded and they're interacting with multiple programs around multiple different health issues. We've been able with these evaluation findings to see how learnings from the Data Academy can be flexible to other outcomes of interest, and that our curriculum doesn't necessarily need to build to a COVID-specific data explorer, but that there are a wealth of tools out there that allow community partners to get information about their communities and use that to make decisions. So we're really looking forward to adapting this for some different audiences, including programmatic staff, to be able to reinforce learnings that we've given to community leaders, as well as opening up other opportunities for members of the community to receive this kind of training in and out within the HES network, as new staff are coming in all the time, and for community partners that exist outside of the HESs. Those are really our next steps based on the learnings from this evaluation, and it's been fantastic to be here with you all today. Looking forward to hearing from the next groups. We're happy to take questions at the end.
Thanks so much, UW-PHI, Rido, and Brown for your presentation. I'm going to hand it over to my colleagues at Texas Health Institute and the Maricopa County Department of Public Health for their presentation on their NEPS evaluation study. I'll transition it over to Emily Peterson-Johnson.
Thank you, Dana. And thank you to all of the NNPHI and CDC teams just for the opportunity to conduct this work and tell you about it today. So I'm Emily. I'm with the Texas Health Institute and was part of the evaluator team. My colleague Jess can't join us today, but of course made valuable contributions to the project. I'm going to have my collaborators at Maricopa County introduce themselves and tell everyone a little bit more about the project background.
Hello, everyone. My name is Erin Appelt. I'm a program evaluator with Maricopa County Department of Public Health in Arizona. And you'll also hear from my colleague, Alexis Arlick, later on in the presentation. She's an invaluable team member working on evaluation for 2103 funds at our department. Right. So our primary goal at MCDPH with the 2103 funding was to increase the number and variety of community partnerships that we had at the department, especially with organizations who directly serve historically underserved communities and those most at risk for COVID-19 and associated health inequities. One way we sought to do that was through creating funding opportunities for CBOs to apply for. And prior to creating those opportunities, grant staff hypothesized why we didn't already have strong relationships with many of these organizations and determined that we could make the following changes to reduce barriers to financial partnership with Maricopa County Department of Public Health. First, we offered 40% of the contract budget upfront at contract execution, as opposed to a more typical cost reimbursement payment schedule, which is what the department had previously used for the most part. we increased collaboration among the staff that would be working with these organizations to align deadlines and streamline communication. And then we hired additional staff who are really dedicated to monitoring those contracts and building relationships with community organizations. All this took place as one part of several strategies to increase our reach to underserved and at-risk communities, include their voices and priorities in our community health needs assessment, share community health needs assessment data back with those communities, and have a community health improvement plan that centers the communities who have been historically excluded and are most likely to experience health inequities. And I will hand things back over to Emily.
Thanks, Erin. So we adopted the effectiveness domain of the REAIM framework to evaluate this. And our primary evaluation question was, to what extent and in what ways has this updated subcontracting process of providing 40% of the funds upfront led to more efficient and more equitable partnerships between community-based organizations and Maricopa County? In order to conduct this evaluation, first THI reviewed a collection of documents which Maricopa County provided us with, and those documents essentially described the program, the process, the timeline, key people involved. And from there, we built out a key informant interview process with 3 separate groups of informants. And so those informants came from either the Maricopa County Department of Public Health or from community-based organizations that were in 2 groups. Either they had never before partnered with Maricopa County other than this 2103 funding, or they had previously partnered with the county and could kind of speak to some differences between this model and previous models. So we conducted those interviews using 3 different interview guides that had distinct questions, but were able to be braided together and provide a more holistic and kind of nuanced perspective of the project. In order to engage participants, we first had Maricopa County identify potential informants from each group, and then the Texas Health Institute reached out to recruit those participants in groups of no more than 9. And in total, we had 15 people who were interviewed. So this represented 6 from Maricopa County, 5 from CBOs that had never previously contracted with the county, and 4 from CBOs who had previously contracted. So we conducted those interviews this spring, and then after we finished interviews, finished analysis, we re-engaged our participants, our key informants, and invited them to review our findings in order to validate them and just kind of ensure accuracy. So I'll explain more about that in a minute. So we transcribed the interviews using a software called Transcribe Me. We used a code book that had 16 primary codes, which we were then applying with both deductive and inductive thematic coding, using a manual process in Atlas TI. And then, as I mentioned, we invited our key informants to review our findings after the analysis was complete. And this is considered kind of a best practice in participatory research because we wanted to have our informants validate our findings and, if needed, provide clarifications or corrections, maybe pick up anything that we as evaluators had missed in our analysis. But I want to acknowledge that that process takes a lot of trust and vulnerability from our partners at Maricopa County because those county staff reviewed the findings concurrent to the key informants from their partners. And so I think that process, like I said, speaks to Maricopa County's high regard for their partners' opinions and also their trust in this evaluation process. So we're really thankful for them working with us in that way. So let's jump into the evaluation findings really quickly to remind you our question in mind is to what extent and in what ways is this updated process of providing 40% of funds up front more efficient and more equitable for partnerships. So our evaluation found there were a couple of very notable positive effects of this model. So one of the first ones was we found that the upfront funding model increased partnerships with smaller budget organizations. So not only did more smaller budget organizations apply for the funding compared to a previous kind of model of the typical cost reimbursement. So more applied and more were engaged, which ultimately increased Maricopa County's partnership network, especially with the intended agencies and organizations to benefit from this model. We also, in the evaluation, found that this funding model allowed smaller budget organizations to really jumpstart their grant activities. So because they had immediate access to funding, those organizations could start hiring right away or just begin the grant activities without needing to kind of worry about floating grant costs, which, as you can imagine, is often difficult for a smaller budget organization. We did find a few limitations worth considering with this model. So one of the first ones in that upper left-hand corner, this is an unintended outcome, but we found that the model kind of accidentally oversaturated some organizations with a lot of funding in a short period of time. One quote from a staff person said, quote, "This process just flooded the market with so much money. And some of these agencies had never seen this much money before, so it became really hard for them to figure out what to do with it." End quote. We also found, kind of moving down to that bottom left corner, we found some informants described one limitation of this model might have been that it involved overwhelming amounts of paperwork or things that seemed infeasible from an administrative standpoint. So some of the paperwork among our key informants was perceived to feel irrelevant or unattainable or even overreaching. It's important to remember, though, that the context is that a lot of these are small organizations with really small staff, and they also sometimes don't always have really established systems for administrative bookkeeping. So as such, like the administrative requirements working with a government entity might feel really infeasible, and in some cases felt like it kind of detracted from their ability to focus on the grant work itself. On that note, we also heard from our informants that to some, the dynamic with Maricopa County felt a little overly formal or non-inclusive, particularly among small organizations. So again, it's important to remember context here. Some of these small CBOs are more used to working in situations where they have kind of very relational, very informal partnerships with community members. And so by contrast, working with a government agency can feel really different. It can feel super formal, super rigid. It can feel a little impersonal, maybe, just kind of by nature of any government entity. So among our informants, sometimes that felt especially pronounced for community-based organizations who work with community members that already kind of have this history of feeling excluded or mistreated by government entities in general. And so that was something just worth noting. And finally, we did hear that there were some concerns about sustainability for this model. So by design, as Erin mentioned, there were more staff involved in this model than maybe a more traditional funding model. But as such, there are questions about, whether that could be sustained or generalized beyond 2103 funding. So some informants also mentioned that the staff at Maricopa County associated with this grant have done a lot of work to really think about how to make their operations and their processes more equitable and more efficient, rather more inclusive as well. And so that important groundwork may not be happening as intentionally or intensely in other departments or other county systems. And that's a really important consideration, because if you want to generalize this model, you have to do the important work that the county staff did in this case, the groundwork of just thinking about, why do we need to be more equitable, more inclusive? What does that look like? And once you do that work, you might be more primed to generalize this model. So that summarizes our evaluation findings. I'm going to pass it back to the Maricopa team to tell us a little bit about some takeaways and next steps.
Thank you, Emily. So we have learned a lot throughout the whole process of receiving 2103 funds, but primarily from this evaluation, we learned that a specific funding structure is less important than flexibility. We are and have been responding to that lesson through providing more flexibility in how contracts are structured. For large dollar contracts, we're asking organizations to propose a reimbursement schedule so that we are structuring that reimbursement in a way that works best for them. For smaller dollar contracts, we're working on reducing barriers to applying by creating short worksheets for organizations to complete in lieu of asking for a large descriptive narrative project proposal. Another lesson that we've learned is that for many of these organizations, working with the government is a major culture shift. It's really interesting to hear about the non-inclusive processes because some of those are in place specifically to make sure that that as a government entity, we are being fair with distribution of dollars and not allowing personal bias to influence funding decisions. And with the few seconds remaining, I will hand it over to Alexis to talk about implementation metrics.
Thank you, Erin. So as mentioned, this process has been very insightful. And so we want to thank PHI for designing an evaluation and making recommendations in a way that we can utilize. So this slide kind of summarizes the status at where MCDPH is with utilizing those various recommendations. In the short term, there are some that seem a little less feasible given the flexibility of government entities and the conversations that still need to happen. As Erin mentioned, there are some things that we have implemented in part, such as flexible deadlines and funding formats. And then a few recommendations that we have implemented in full include hiring more program monitoring staff and those abbreviated funding worksheets for funding applications. So we're still leaning into the flexibility and finding where we can shift and adapt to meet everybody's needs, but we look forward to exploring sustainability with these methods. And I will pause and pass it on to the next presenter.
Emily, anything you want to add before we transition over?
No, thank you so much. We'll wait for questions at the end.
Thanks, Emily. All right. Last but not least, I'd like to first thank THI Maricopa for their great presentation today. And I'm going to hand it over back to University of Michigan for their second site, which is the North Carolina Department of Health and Human Services, as well as the NC Counts Coalition for their presentation on their NEPS evaluation study. I'll transition it back to Dr. Watkins to close us out.
Thank you, Dana. Happy to be back to bring this to a close with last but certainly not least, we're excited to share some findings from our evaluation of some really impressive work that's being done in the state of North Carolina. So I want to begin by just introducing myself again. I'm Daphne Watkins, professor at the University of Michigan School of Social Work and director of the Curtis Center for Health Equity Research and Training, and joined here by some representatives from the University of Michigan team. Though our team was much bigger than this, folks today are Hannah Burgess and Jamie Abelson. And we also have on the call today some representatives from the state of North Carolina. We have Stacy Carles, who is the executive director of NC Counts, and Ava Hardiman, who is also here from the Department of Health and Human Services in North Carolina. And so I'd like to hand things over to Ava and Stacy so that they can share the NEPS that we evaluated. It's called Healthier Together.
Good afternoon, everyone. We are so excited and so honored to be here with you all today. I am Ava Hardiman, and Stacy, my partner in crime, so to speak, in North Carolina, from a wonderful agency of NC Counts Coalition. I just want to share with you, this has been a public-private partnership that came together to address strategy 4, to really focus on that community and partner engagement component through COVID. With this relationship, we were able to establish what we call Healthier Together initiative. And the reason we were able to do that is because of this wonderful person here beside me that had a vision and a dream some years ago to really be able to serve the community and meet them where they are. And with that, NC Counts Coalition was formed. And so they were able to bring to the table in this partnership a number of resources. They serve as an intermediary between the state and community-based organizations across the state that are frontline boots on the ground. And with those resources, they bring an infrastructure of how to be able to work with those communities. And they also had part of their resources an existing network and trusted relationships across the community as well, and many different population groups that meet and represent H&P, or historically marginalized populations, or BIPOC populations. And with that, those folks were the trusted messengers that have been able to provide different types of resources and services that are part of their many programs and services that their agency offers. And so with that, they've been able to work with us in so many different ways through COVID, being able to meet the needs and respond in real time and increase our reach across the state. So we have, as you see on the screen here, the Healthier Together actually brings together the department's team, our communications office, our collaborative, our program management staff, and consultant group of Ernst & Young, as well as our office with the Health Equity Portfolio, Office of Health Equity, and then some of their communication team, Hey Awesome Girl and Neiman Collaborative, and then about 48 or more community-based organizations. Next slide, Dr. Watkins. And so here just provides you just a brief timeline. I won't go through all of this, but when you get the opportunity to look at it a little closer. But from the onset of Healthier Together initiative, we were able to, through this partnership, be able to meet that demand in so many different ways, where community-based organizations, because of their leadership, coaching, and mentorship, were able to make things easier for the communities, equip them, and prepare them to be able to provide the outreach and services that were needed. So this timeline will provide those things for you. This was truly a community-driven, a community-centered, and community-led initiative, and continues to be, to build the resilience of communities for community and partner engagement. And next slide, Dr. Watkins. And we'll pass it back to you.
Thank you, Ava. And so we here at the University of Michigan had the honor of evaluating Healthier Together for our colleagues in the state of North Carolina. And so we framed two overarching evaluation questions based on the effectiveness dimension from the REAIM framework. So the first question was, to what extent was Healthier Together effective in increasing relationships among stakeholders, such as historically marginalized populations, community-based organizations, vaccine providers, NC Counts, and the Department of Health and Human Services? And then our second evaluation question was, to what extent was Healthier Together effective in increasing the number of vaccinations for individuals from BIPOC communities and historically marginalized populations? And so in order to answer these evaluation questions, we used a participatory evaluation approach to assess the effectiveness of the short-term outcomes for Healthier Together that were laid out in their logic model. We used 3 different data sources. The first was existing documents that were shared by the Healthier Together colleagues in North Carolina. We also reviewed statewide data, and then we conducted some qualitative interviews. And so we completed a total of 24 interviews from 4 different groups in the state of North Carolina. We had people representing the North Carolina Department of Health and Human Services staff. So we interviewed 9 people from the staff. We also interviewed 7 people from the NC Counts staff. We interviewed 5 funding recipients and then 3 external collaborators. As for the analytic plan, we analyzed the data using a modified version of the rigorous and accelerated data reduction technique. And we also reviewed external data sources to address our evaluation questions. So when it comes to the results, we are going to first talk a little bit about answering evaluation question number 1, which was, to what extent was Healthier Together effective in increasing relationships among the organizations and individuals involved in the initiative? And our evaluation team determined that over time, Healthier Together was effective in increasing some relationships among organizations and individuals involved in the initiative, though we also acknowledge that not all relationships evolved in the same way. You can see from this slide that after rigorously reviewing the data, we identified 3 themes that helped us address the first evaluation question. These themes really speak to the way in which Healthier Together increased relationships. For example, Healthier Together built capacity for connections. There was also an intentionality in developing and preserving relationships during Healthier Together. And finally, Healthier Together outlined a blueprint for future partnerships and collaborations. And so in order to answer evaluation question number 2, we also poured through the pages and pages of qualitative data. And again, question number 2 really focused on, to what extent was Healthier Together effective in increasing the number of vaccinations for individuals from BIPOC communities and historically marginalized populations? And our evaluation team was really guided by the interviewees' perspectives when it came to whether Healthier Together was effective in increasing vaccinations among BIPOC communities and members from historically marginalized populations. Now, on this slide, you can see that we identified 3 themes generated from the qualitative data to help us address this second evaluation question. The first theme underscored the Healthier Together approach. The second theme really focused on reaching versus engaging BIPOC communities and historically marginalized populations. And the final theme focused on interview participants' perspectives around vaccine distribution and outcomes. Now, before I share recommendations from the evaluation team about sustainability and future plans, I want to share a NEPS highlight, which really speaks to how effective having an intermediary organization can be in bridging the gap between the community and the government. So in short, this worked well in North Carolina, as the main issue was that community members, community-based organizations, and the government in North Carolina really struggled to collaborate on public health initiatives. And so North Carolina's Department of Health and Human Services was able to reach the community and really bridge that gap by partnering with NC Counts as their intermediary organization. And this was seen as a huge success. So having NC Counts serve as this intermediary worked really well in this particular case. And so in closing, as we look to our colleagues in North Carolina, the Department of Health and Human Services and NC Counts, the evaluation team have a few suggestions, essentially some takeaways that we'd like for them to consider. The first is to maintain the relationships that were built through Healthier Together. The second is to uphold the use of a regional team model. What we learned from the interviews and the existing documents is that model seemed to work really well. We also encourage our colleagues to seek renewable funding and leverage resources to sustain Healthier Together, to consider standardized data-driven approaches when addressing health disparities. And again, just going back to this idea of an intermediary organization, it worked really well in this particular process. And so ways that we can continue to use that and improve that in the working relationships and engagement between community and government is definitely something that should be considered in the future. And then finally, increasing transparency about the length of funding and contract renewal. So making sure that things are crystal clear when it comes to partnering with different groups across the state. And so with that, I'll hand things back over to Dana.
Thanks so much, Dr. Watkins, and Stacy and Ava as well for your presentations. It was really great to hear from you all. And I would like to thank all of our partners and eval sites for their presentations. We're now going to open it up for Q&A.